Good afternoon. My name is Amara Anosike, and I'm the Director of Behavioral Health Policy and Advocacy at Boston Children's Hospital and on the leadership team of the Children's Mental Health Campaign. I will be acting as your moderator for today's session. On behalf of everyone at Boston Children's Hospital and the Children's Mental Health Campaign, it is my privilege to welcome you to today's webinar, Turning the Tide on the Children's Behavioral Health Crisis, a Spotlight on Workforce. We have convened this discussion in the midst of a behavioral health crisis nationwide, with the goal of outlining actionable solutions to begin to address the pediatric behavioral health workforce shortage that we currently face. We have over 550 registered attendees who are tuned in today. Stakeholders far and wide, including parents, clinicians, lawmakers, advocates, and the media, have signed up to be a part of this discussion, both today and moving forward. Before we begin, I would like to get a few housekeeping matters out of the way. This webinar is being recorded, and everyone who is registered will receive a link to the recording and a copy of the slides. Additionally, if you would like closed captioning for a live transcript of today's webinar, please click the button at the bottom of your Zoom screen that says live transcript. This will enable the closed captioning on your screen. Lastly, due to time constraints, we will not have a Q&A session, but please do email any questions to the Children's Advocacy Network at can@childrens.harvard.edu. can@childrens.harvard.edu. Okay, let's get right to it. We have a great session today. I first have the honor of welcoming the CEO and President of Boston Children's Hospital, Dr. Kevin Churchwell, who will open today's session with a few remarks. Welcome, Dr. Churchwell.
Well, good afternoon, everyone. Thank you for joining us as we come together to discuss the children's behavioral health crisis with a special focus on workforce. As I reflect back on everything we have overcome as a hospital community and society with the COVID-19 pandemic, I'm encouraged by our collective resilience. And yet, I realistically know we have our work cut out for us as our children continue to navigate the behavioral health crisis. As a pediatric provider, our hospital was uniquely positioned to recognize the need for reforming the pediatric behavioral health system long before the COVID-19 pandemic, which only heightened the need for widespread access to quality behavioral health care for children and families. More than 16 years ago, we were a founding member of the Children's Mental Health Campaign and helped sound the alarm on the state of children's mental health system in Massachusetts. Since then, we have worked with the campaign, families, advocates, legislators, and partner organizations to help enact behavioral health legislation and fund necessary services. However, this is not just a local crisis. It is a national crisis as well. So we are engaging in advocacy on the federal level in collaboration with the Children's Hospital Association, CHA. And bottom line, we are devoted to doing everything we can for children's health, even for the children who will never come through our hospital doors. We've pushed policy change. We also committed as an organization to enhancing and expanding our behavioral health capacity. In the past few years, we've expanded our outpatient services in both Longwood and Waltham, opened a new inpatient psychiatric unit in Waltham, and continue to provide collaborative behavioral health services in primary care through our behavioral health integration program, and in schools through our Boston Children's Hospital Neighborhood Partnership Program. We have also announced an affiliation with Franciscan's Children's Hospital to increase access to better and more coordinated care across the full continuum of care, to invest in our workforce, and to support the development of cutting-edge research. As we continue to do everything we can to ensure equitable access to quality behavioral health care for all children, I want to thank each and every one of you I want to especially thank the nurses, our social workers, physicians, psychologists, family partners, our security staff, and others who have helped us manage this crisis. Thank you for your engagement and commitment in this space, whether that is through direct clinical care, administrative efforts, or advocacy. We could not do this work without you. I'd like to also thank those who will be speaking during today's session. We have a courageous caregiver who will be sharing her family's story on navigating the behavioral health care system. A clinician, advocates, and policymakers, including Attorney General Andrea Campbell, U.S. Senator Ed Markey, U.S. Representative Jake Auchincloss, will be here today, and thank you all for being part of this webinar. Thank you for taking the time to share your expertise and engage with us in this important discussion. With the majority of behavioral health conditions beginning in adolescence, we have both a responsibility and an opportunity as a society to invest more in the behavioral health needs of our children now, to help ensure a better future, not only for them, but for all of us. Thank you.
Thank you, Dr. Churchwell, for your remarks today, and most importantly, for your steadfast leadership. Our next speaker is Massachusetts Attorney General Andrea Campbell. AG Campbell has long been a champion for the people. She was elected in 2015 to serve on the Boston City Council, becoming the first woman to represent Boston's 4th District. In 2018, she was unanimously elected to serve as the president of the Boston City Council and was the first Black woman to hold the title. As Attorney General, AG Campbell has committed to prioritizing the promotion of mental and behavioral health services for all children and individuals in the Commonwealth. Attorney General Campbell, everyone.
Thank you, and hopefully you all can see and hear me okay. Delighted to be with you today, and I want to first say good afternoon, everyone. And I want to thank, of course, all of you who made today possible, from the panelists to the staff, to all of you who are tuning in. I also want, of course, to express my sincere gratitude and appreciation for Boston Children's Hospital for creating this space. I want to thank all of the providers who are on the front lines every single day, ensuring our children are taken care of, are supported, are empowered in a way that's culturally competent and inclusive. I know today's conversation is primarily focused on our workforce and all the ways we can work in partnership to address the shortage and expand the pipeline. We all know a strong, diverse, talented workforce is essential, and my office is committed to ensuring there are protections for those workers, to ensure you work in a healthy, safe environment, of course, that's free of discrimination, and where wages and benefits are paid and paid on time. As Attorney General, I also know there are ways to work with the governor's administration and, of course, all of you on incentives, pay, and workforce development, partnerships with high schools and colleges, especially our community colleges, to address the issue. It's no secret that our young people today are struggling, especially with the collective trauma we are all feeling from the pandemic, the incessant shootings and violence we are seeing in this country, the uptick in hate, bullying, harassment, and so much more. Because of these issues, and as a mother of 2 young boys, ages 3 and 5, an absolute priority for the office is and will be protecting the mental health and the physical and emotional well-being of our children. While I'm fortunate that my kids are young and not engaged in certain behavior or on social media platforms, I'm absolutely aware of the uptick in anxiety, depression, and suicide and suicidal thoughts amongst our youth, an epidemic that exists here in Massachusetts and, of course, across this country. First, I know that through our office's Healthcare Bureau and working alongside all of you and the Health Policy Commission, we can do the work of ensuring our youth have access to mental health, behavioral health services, and begin to have conversations, and most importantly, take action on the cost, the quality, the lack of access, and the difficulty in finding a provider. We thus know we must show up and engage in workforce development conversations. We will also fight for our residents here and across the Commonwealth and across the country to have access to gender affirming care, as states all across this country are putting out misinformation in an effort to deny this critical care. But we can do more than that. Just a few weeks ago, I joined attorneys general from across the country to announce a $462 million multi-state settlement where Massachusetts will receive $41 million. It was a settlement with Juul for their role, an active role in contributing to the youth vaping epidemic we are seeing nationwide. When they burst on the scene, their conduct was irresponsible. They intentionally targeted young people, aggressively marketed their vapes and e-cigarettes using influencers and all types of information to target youth to get them hooked to be able to build a profit. While I'm extremely proud of the work the team has done, of course, for this settlement, there sadly are more entities that are looking to harm our children. Social media companies, while there are some benefits, there are also devastating consequences. So we are investigating the mental health impacts of social media on youth, taking on social media giants like Facebook, Instagram, TikTok, and others, where there's substantial evidence that young users who use these platforms, especially young girls, are seeing an uptick in depression, self-harm, anxiety, and so much more. And in a divisive political climate in this country, it's actually a bright spot in that Republican and Democratic AGs from across the country agree that there's work and significant work to do in this space. We also are taking on bullying and harassment in our schools, providing trainings and regional trainings all across the Commonwealth in every single county to make sure our school administrators, for example, have the tools and everything they would need to address bullying and harassment in school sports, but also in their school settings. We know these trainings are critical for developing an understanding and, of course, striving to create a Commonwealth and a country where religious, racial, ethnic, sexual orientation diversity is centered, and that it is, of course, important and prioritized to make us the best Commonwealth and the best state in the nation. And as our office continues to have internal and external conversations with respect to this work, we hope that you will be in touch with us, that you will do everything in your power, of course, to work in partnership with us. We look forward to working with you. We look forward to you informing the strategic plan and, most importantly, rolling up our sleeves to get the work done. Thank you to everyone who has created this space, and most importantly, thank you for the work you do every single day to protect our children. Thank you.
Thank you, Attorney General Campbell, for your dedication and advocacy during this critical time of need. Next, we have Tara Agrawal, who is a parent of a child with behavioral health needs and brings a unique and necessary perspective to the conversation.
Thank you, Amara, and thank you to AG Campbell and Dr. Kevin Churchwell for all that you and your teams are doing to support families like us across the Commonwealth. Good afternoon. My name is Tara Agrawal. I am mom to a race car obsessed 3-year-old and a science loving 7-year-old named S. My husband and I both work full-time. I work as a healthcare administrator, and my husband works as a lawyer for the United States Department of Labor. Today, I am here to share our family's story with trying to find behavioral health care for our young son, S. Last fall, within the span of about a week, S's behaviors had rapidly declined at home. He became unable to dress himself without our help, struggled to stay regulated, and began using negative self-talk. We did not have a psychologist or psychiatrist for S because up until this time, he had been a well-functioning child. But 2 days before Halloween, S's behaviors reached a crisis point. So without knowing where to turn, my husband brought him to the emergency department. In the ED, we were told we could be there weeks waiting. S was boarded in a windowless room for 5 days. We were with him around the clock. He was not allowed to leave his small room except to go to the bathroom. He had no access to fresh air, sunlight, or a place to be active. His appetite and mood deteriorated. Eventually, we learned that S had been leveled for an inpatient psych bed. Given S was so young, It was hard for us to imagine admitting him to a place where he would be separated from us. In Massachusetts, we learned there are only 2 inpatient units in the state that take children as young as 6, and only 1 unit that allows parents to stay overnight. So S was offered a bed at the only facility in the state that takes 6-year-olds and allows parents to stay. With no other appropriate option, we accepted the bed. When we arrived, we were disturbed that S was given an ankle monitor and that he would have to play in a locked hallway with limited outdoor access. S expressed to us he was scared of the bigger kids and wanted to go home. It was quickly determined that S would be discharged because the level of care and environment were not appropriate for his condition or age. We were shocked to learn that upon discharge, we would have no appointments lined up with any behavioral health providers. The few referrals that were made, we've never heard from, and this is shockingly common. So we've relied heavily on our colleagues, parents, siblings, and friends. It's only been with their help that we found S's providers and gotten meals on the table. The financial, time, and emotional strains on our family have been overwhelming and excruciating. It took us months to find a qualified provider to begin treatment for S. Though that's not fast enough, that's lightning speed because we're still on wait lists. While we waited, we had to manage S's psychological needs without the skills to do so, and also care for his younger brother and report to our jobs. The providers we found don't take insurance, and we've had to buy a second car to get S to his appointments. We've had to cut back on work, and we've looked into moving to a lower cost area. Our young son was in a mental health crisis, and the first 2 places we turned, the ED and the inpatient facility, were not able to get us the help we needed, nor were they able to connect us to appropriate therapeutic options. While I'm not sure I have answers based on our family's experience, I do have some questions that might guide us forward on these issues. What would it take for families to know about the resources available to us and where we can turn when our children are experiencing a mental health crisis? What would it take to have young patients connected to appropriate mental health providers when they are discharged from facilities so that treatment continues without pause? What would it take to have a sufficient supply of qualified providers without lengthy wait lists and who accept insurance? What would it take to equip pediatricians with the referral networks needed to connect children to appropriate mental and behavioral health treatment? What would it take to equip what would it take to build out community and in-home resources to allow children to stay out of the ED and inpatient facilities in the first place, and then attract and retain qualified providers to perform services in those settings? Our family and so many families across the Commonwealth are just utterly unprepared when their children meet with a mental health crisis. We worked around the clock to get him the care he needed. For parents without well-resourced social networks, the situation is even more dire, and the inequities are stark. Children and families in Massachusetts need and deserve a mental and behavioral health system that is able to deliver care with the urgency and appropriateness that matches our children's need for help. The future health and well-being of the Commonwealth depend on it. Thank you for this opportunity to share our family's story. We look forward to continuing the conversation with you.
Thank you, Tara, for sharing your harrowing experience with us. We've all heard of the numbers, we've all heard of the data, but it is important to always remember the human stories behind those figures. I would next like to welcome Scott Nesiba, Vice President of Behavioral Health Nursing and Patient Care Operations at Boston Children's Hospital, who will be providing us with what he sees as a viable solution to the pediatric behavioral health workforce crisis. Please welcome Scott.
Thank you, Amara, and good afternoon to everyone, and thank you all for joining the webinar today. Also, I want to echo the comments that are coming in the chat right now. Thank you, Tara, for your willingness to share a very personal story. And I think it's important that we all acknowledge that these stories are, of the utmost importance for us to hear and to understand the reality of parents navigating the behavioral health system today and the difficulties they face, as those experiences are the only way to help us understand how to make improvements. So thank you very much for sharing that. So I'm Scott Nesiba, and I'm the Vice President of Behavioral Health Nursing Patient Care Operations here at Boston Children's Hospital. And I am delighted to be here today in this webinar to talk about where we are in the pediatric behavioral health crisis, and more importantly, how we continue to engage our workforce as a solution to addressing this problem. Our goal is and will always be to deliver care that is compassionate to the unique needs of the patient and the family, regardless of where that care is delivered. So the first slide will be sort of a little brief introduction of how did we get here today. And by now, I think we have all heard about and are very aware of the pediatric behavioral health crisis taking place in this country, and in many factors that have brought us to this point. The historical lack of awareness, failure to prioritize mental health in the past, difficulty assessing care levels at various points in the continuum of services, as we've just described, as well as workforce issues, including training and shortages of behavioral health trained staff appropriately to address behavioral health needs. So in addition to that, what we've seen over the past 3 pandemic years is really an exacerbation of what was already an increasing rate of children and adolescents presenting with behavioral health disorders. So the pandemic has had negative effects on youth, as indicated here on this slide, including less physical activity, less time outdoors, more social isolation, and spending more time in front of screens. As you all know, in 2021, the Children's Hospital Association and the American Academy of Pediatrics declared the behavioral health crisis a national emergency. Now, here we are in 2023, and the emergency continues, with 1/2 of US adolescents now having at least one behavioral, mental, or emotional disorder. So I wanted to talk about what this looks like on a day-to-day basis in the hospital. And what it looks like is a persistently high number of dysregulated children and adolescents. And these poor kids are presenting with serious attempts to harm or kill themselves, and or having aggressive behavior towards the family, peers, or others in the community. In the hospital setting, this behavior has also increasingly been directed towards hospital staff. And so understandably, parents and families are shaken by this, and they're desperately searching for help, as we just heard. So knowing that we have these huge numbers, on the next slide, I want to talk a little bit about where kids in crisis go and where they're receiving care. So currently the landing spot for the majority of children's experience in mental health crisis is an emergency department. And from there, as we just heard, due to the high numbers and the acuity of patients, there's often not an immediate plan that feels safe for parents and families. This means these children are frequently ending up in areas of our healthcare system that were not designed to provide care for them, namely by either remaining in the ED or being boarded, as is described, on a medical or surgical inpatient unit. And I really want to advocate to everyone that children in behavioral health crises deserve more from the system than they're getting. So we talk about boarding, and the next slide shows sort of the trends that we've been seeing from 2016 through 2022 around how many kids are being boarded and what is it actually, what are the numbers. So this slide shows the trends that we have seen in the number of children boarding or waiting for the higher level of care bed from 2016 to 2022. We did see a dip in 2022 from that pandemic-driven high of 21, but the numbers are nearly double what they were 5 years ago. And so what do these numbers represent? And what is it like to be a kid boarding and waiting for services? And just to reiterate again, the story that was just told, it's hard, very hard to be a kid with high mental, emotional, and behavioral needs, trying to navigate and get through it in an environment that was not designed for you. It's also stressful for parents to feel like the care is on pause or to see that their child is remaining in that situation. And then finally, in addition to patients and families, it's hard for nursing staff to provide complex emotional support to these kids while also having to manage acute medical and surgical needs of the other patients on these medical floors right next door. So on the next slide, it goes a little deeper into the pandemic's impact on the psychiatric boarding. And so what this graph shows is along the bottom, you'll see the number of unique patients by month that was boarding each month at Boston Children's Hospital, and also the total number of days that were spent boarding or waiting for a bed in the line graph above. So again, you can see that the good news is that in the second half of 2022, we did see some decreases in the total number of days that we had kids boarding for beds. This is likely due to around October 2022, there were additional inpatient beds that were quickly brought online in the community, but we can see that the overall trend remains increasing. The challenge for these patients that are boarding and experiencing this difficulty is not only caring for patients in a non-therapeutic environment, like we're forced to now, but that their unique safety needs often require additional one-to-one staff to supervise them and keep eyes on, and ideally understanding that ideally staff that would understand, behavioral health diagnosis and treatment plans as well. It is also challenging, as mentioned previously, to find appropriate resources for patients discharged back into the community. And they can have an extremely long extended stay in these environments, and you can see by some of these numbers. So when a behavioral health patient stays 100+ days on a unit that was not designed for them and receives care from staff that are not trained specifically to care for them, realistically increased dysregulated behaviors, frustrated parents, and caregiver burnout are often the results. And I don't know how we would expect anything else in that. So that's the problem. So moving on to what Boston Children's response has been here on the next slide. And I would say our response has been and will continue to be multifaceted. It has included expanding services where they were needed, such as quickly opening up a new inpatient unit during the pandemic in 2022, resulting in at least the part of the decrease in boarding shown on the last slide. Also has included improving our ability to get patients directly into the right program at the right time. And we've done this by expanding our outpatient service offerings, including integrated behavioral health care in primary care and in school-based studies. These upstream investments are critical to preventing downstream needs that lead to boarding and have various other impacts on children, their families, and the workforce. When it comes to our advocacy work, our coalition partners such as the Children's Mental Health Campaign and Children's Hospital Association, I cannot say enough about how critical an intervention that is. Many of these issues start at the policy level, and I'm grateful to know that at Boston Children's and folks like Amy and Danna, who you will hear from, are working on this issue by advocating for policies that increase access to quality care. You will hear more from Amy and Danna on some of these advocacy efforts later in the program. We also have made sure to engage in partnerships with other providers to leverage the workforce and support the continuum of care. As Dr. Churchwell mentioned, we're partnering with Franciscans Children's, where they have amazing behavioral health programs that we intend to expand upon together. We've also partnered with community-based providers like youth villages and JRI, and with the state such as the Department of Mental Health on an ED diversion program. And this program has been hugely successful at enabling children to return home and access services in the community, rather than continuing to board. I'd also like to thank the Attorney General, Andrea Campbell, and her office for providing us with a grant to expand our ED diversion program. So finally, one current area of focus is expanding our ability to provide crisis intervention services for patients that are boarding. So that's one of the solutions, and the final one I'll talk about today on the last slide. And acknowledging we still have more to do. So during the pandemic, some of the things we saw was a rapid expansion of our behavioral response. The BRT is able to partner with social work, psychiatry, and our psychology teams and function in various ways across the hospital to help everyone provide more collaborative and trauma-informed care. What this looks like now for patients boarding in our 6-bed medical and behavioral health cohort is that they now receive their care through team-based interventions that involve both medical and behavioral health staff. From BRT, this means behavioral health nurses, techs, counselors, and BCBAs, as well as consultation and support from social work, psychiatry, and psychology. This also has the effect of supporting and educating the medical nursing staff that remain involved. And in the cohort model, they report feeling better positioned to provide higher quality and safer care. For patients outside the cohort, the goals have been similar. The medical nursing staff are rounded on by our proactive team of behavioral health caregivers to plan care, visit with patients, and provide on-the-spot training. The behavioral response team is in a unique position to collaborate with social work, psychology, and psychiatry to ensure we have consistent and evidence-based plans of care that are considering patient and family needs. We've adopted and implemented well de-escalation training across multiple areas in the hospital. This provides enhanced de-escalation training in a flexible way, right to the staff in the areas that are seeing the highest risk patients. This training empowers all staff to speak the same language of engagement, de-escalation, and empathy towards our patients. Finally, and maybe the most exciting, has been working to expand and develop the future workforce through our partnership with William James College. This partnership is working to recruit cohorts of diverse individuals from within our local community and providing them with the behavioral health specific training and education needed to provide care in a trauma-informed way to kids that are forced to board while waiting for a bed. This training program prepares individuals with the skills needed to sit with and engage these children in care for simply boarding and waiting for a bed. I'm really excited to see all of these programs as they continue to grow and develop and help bring more kind and compassionate behavioral health care to patients, regardless of their care location. Thank you, Amara.
Thank you, Scott, for educating us on the current state of the crisis and also for sharing critical solutions. Joining us next is Amy DeLong, Director of Federal Government Relations and External Affairs at Boston Children's Hospital. Amy works closely with the Children's Hospital Association and will be sharing information on current federal initiatives to strengthen the pediatric behavioral health workforce. Amy DeLong, everyone.
Thank you, Amara. My name is Amy DeLong, and I lead our federal advocacy efforts here at Boston Children's. That is to say, things that are happening at a national level, whether it's legislation under consideration or actions taken by federal agencies that impacts children and how they receive health care. In doing so, I partner with CHA and a lot of our peer institutions, other children's hospitals from across the country. And this has always been how we're most impactful at the national level, because the Congress is obviously comprised of members from all across the nation, and we need to have reach into offices of elected officials beyond Massachusetts and New England in order for our priorities to advance. Through my work with CHA and other children's hospitals, I can confidently say Boston Children's Hospital and the state of Massachusetts are not alone in this child mental health crisis, nor the contributing behavioral health workforce crisis. It's happening nationwide to this kind of serious degree. And in addition to attention at the state and local levels, it calls for federal solutions. So this crisis really predates COVID and has taken a long time to get to this point. So there's no one immediate solution or bill that can solve this, but there is one piece that must be addressed in order to make any progress for the future, and that is sustaining and building a strong workforce. As Scott mentioned, a year and a half ago, CHA joined with the AAP and also with ACAP to declare the child mental health crisis a national emergency. One of the founding principles of the campaign that we built around this declaration was to support the pediatric mental health workforce, prioritize strategies to address longstanding workforce challenges in the child mental health area, and to intensify efforts to recruit underrepresented populations into both clinical and non-clinical mental health professions. Any federal behavioral health legislation that is to be comprehensive needs to address the workforce, and that clinical and non-clinical language is really key in order to be successful. So together with our peers, we are working to safeguard the pediatric workforce through advocacy and other improvement initiatives. And I've outlined some of the efforts underway on the next slide. Actually. So this is calls for national solutions. There we go. I do want to call out on this list one bill that is bipartisan and was recently reintroduced, called the Helping Kids Cope Act. We will soon be working with our partners, with everyone, to collect co-sponsors for it. The bill would authorize grants to support pediatric mental health care programs in communities across the country. A component is to provide funding to support training and other workforce innovations at children's hospitals and other pediatric delivery settings, other settings related to pediatric behavioral health. The bill's lead sponsors will be making an announcement about that bill this week, also in recognition of Child Mental Health Week. And we will be working with our New England delegation and other champions to support the bill and hopefully see it advance. And speaking of our congressional delegation, we are excited to be able to share some perspectives with them from you today. I want to introduce two virtual speakers who are members of the Massachusetts congressional delegation and real champions on this issue. Senator Ed Markey from Massachusetts and Representative Jake Auchincloss, also from Massachusetts. They represent us in the US Congress and have been particularly accessible and engaged on these issues. Senator Markey, important to note, has a new committee assignment this year on the Senate committee that has the authority to advance a lot of health and mental health related legislation. So we're thrilled to have his support and understanding of this crisis. Representative Auchincloss is one of the newer members of the delegation, and he's jumped in with both feet on all things related to child mental health. I think as a father of young children himself, he seems to sense the urgency. So we are thrilled to have their support, and I want to turn it over to show their remarks at this time.
Thank you, Boston Children's Hospital, for the invitation to participate virtually in this very, very important webinar. I can't overstate its importance because children may be 20% of our population, but they're 100% of our future. And doctors, nurses, physicians assistants, certified nurses aides, therapists, and other providers caring for sick children today are securing the health of the leaders of tomorrow. They are our heroes. And what do they work on? Well, they work on ensuring that the Commonwealth's children who are showing symptoms of distress get the help they need, because social isolation, loss from COVID-19 pandemic, unregulated social media, intensifying impacts of climate change, discrimination, economic insecurity are driving children and teens to anxiety, depression, substance misuse, and, unfortunately, suicide. Instead of meeting this crisis with more pediatricians, more nurses, more child psychiatrists, many of these positions now sit empty. Fewer people are training for pediatrics, and many, burned out by the weight of the care they are providing, are leaving the health workforce entirely. And when kids ask for help, they're faced with long waits to get the care that they so desperately need. So from my perspective, Congress must step up, must provide the resources necessary to address this crisis and make pediatric behavioral care available to our nation's children. In my role as chairman of the HELP Committee's Primary Health Subcommittee, I am fighting to invest in children's hospitals, graduate medical education, expand the pipeline of providers, and ensure that workers get fair pay and safe working conditions. We have to treat them in the same way that they work to treat us as patients. I am also fighting to address the crises that are undermining children's behavioral health by taking on big tech, investing in communities, building resilience to climate change, and strengthening prevention and treatment of substance use disorders. This is a crisis that we are in, and the choices that we make today will affect the health of Massachusetts and the country for decades to come. Congress must step up to the plate and support our future by supporting our children and their health providers. Thank you all for everything that you do. Thank you for your service. We have to get you the help you need in order to help all of those who are in need in our society. Thank you. Thank you.
Hey everyone, Congressman Jake Auchincloss here. I'd like to thank Boston Children's Hospital and the Children's Mental Health Campaign for putting together this webinar. As a parent, I understand that children's mental health care is a critically important topic. We need to bolster this workforce to ensure care is accessible for all children. And we need people like those assembled here to bring forward solutions and serve as advocates for children. Urgent action is needed to expand capacity to deliver appropriate care to meet children's mental and behavioral health needs. There are shockingly few options for children in need of mental health treatment, and too often children go without necessary care, resulting in more serious mental health conditions. On the federal level, I am working in Congress to expand the children's mental health workforce. Last session, I supported legislation to increase children's hospitals' capacity for behavioral and mental health services, legislation to develop and grow the pediatric mental health workforce, and legislation to train frontline healthcare providers working with children with or at risk of eating disorders. I also recognize that if we do not invest in a culturally responsive workforce, then we will not be able to meet children where they are. That is why I supported legislation specifically aimed at increasing culturally competent mental health services to support youth of color. I am particularly grateful that this forum includes people at all levels of government, because that is what is needed to address this crisis with the urgency it deserves. I look forward to hearing about the rest of this discussion and will continue to advocate for children's mental health in Congress.
Thank you, Amy, U.S. Senator Markey, and U.S. Representative Auchincloss for joining us today. We know that children's behavioral health crisis is a national challenge, so we appreciate you bringing a nationwide perspective. I would next like to welcome Dr. Danna Mauch, President and CEO of the Massachusetts Association of Mental Health and an executive committee member of the Children's Mental Health Campaign. Dr. Mauch will be sharing her expertise on the children's behavioral health policy landscape in Massachusetts. Please welcome Dr. Danna Mauch.
Hi, thank you very much, Amara, and thank you also, Dr. Churchwell, for hosting this event today and bringing us all together. It's my pleasure to be here to talk to you today about some of the developments in state level workforce policy, resources, and solutions. The Massachusetts Association for Mental Health was fortunate to work in this last year to gather knowledge that we hope could inform policy and action. So today I'd like to present to you some key findings from an inventory of services and initiatives designed to strengthen the behavioral health workforce in the Commonwealth, and also policy and program opportunities to grow and diversify the pediatric behavioral health workforce. So if we could move to a couple of slides ahead. I want to note for everyone that our gratitude for support that was provided by the Blue Cross Blue Shield of Massachusetts Foundation, the CF Adams Trust, and the Metro West Health Foundation in our efforts to do this work. The purpose of developing the inventory, as I said earlier, at writ large is to really inform policy. We wanted to identify policies already in place, programs and incentives that are designed to recruit and retain, expand and sustain the behavioral health workforce. But again, the critical thing is to help us better understand the scope of workforce challenges, the tactics and strategies that can be effective in strengthening the capacity and size of the workforce, and really to inform our future initiatives and workforce development. So let's talk about the first finding in the from the study, which has to do with individual provider incentives. The most frequently offered incentives, most commonly offered incentives actually come directly from providers, whether that is Children's Hospital, our host today, or a variety of clinics and programs across the state. In order to recruit and retain a qualified workforce, they have of necessity needed to implement a number of incentives. However, I want to note that these have not been systematically executed across either provider types or service sectors, and I will get back to this as we talk further. There are various recruitment incentives, particularly hiring bonuses that behavioral health agencies in the Commonwealth have been using to try to hold on to or attract the workforce. And these are critical, but I want to note they've been unevenly distributed across the Commonwealth, in part because providers have not consistently had all of the resources they needed to get the job done. There are federal scholarships and loan forgiveness programs that people in the behavioral health field can access. However, they are really designed for the broad range of public health positions and aren't often targeted specifically to the behavioral health workforce. We need targeted solutions. In the next slide, you'll see a illustration that indicates how many incentives in our study were actually offered by particular settings. Not surprisingly, the largest number of incentives offered, often bonuses or hiring bonuses or stay bonuses, were in community and residential services. It's important to know that in those settings, according to studies conducted over the last 2 years, the vacancy rates are high. Depending on the licensure level, frontline workers in some parts of the state, they have an excess of 40% vacancy rates. Among licensed clinicians, the Association for Behavioral Health Care has found that they have 29 to 30% vacancies. Again, depending on what part of the state you're in, it could be higher. You'll see that there are very few investments in schools, which is ironically where children spend most of their time. But these are, don't have as many staff. You'll also notice that hybrid community services and telehealth offer fewer incentives, even though during COVID, the behavioral health field pivoted largely to delivering one-on-one psychotherapy through behavioral health. So let's talk about the next finding, which has to do with Massachusetts' efforts to expand workforce development efforts. You heard some of these referenced earlier, but there are two main pots of money that have been spent, one on loan repayment, to date, more than $135 million. You'll see how this is broken out, these details. I would say the important thing to understand here is that some of the loan repayment programs are quite generous for a psychiatrist or someone with doctoral level degrees. It could be up to several $100,000 to repay the costs of education and training. There are some targeted sums in this to child and adolescent psychiatrists. In exchange, practitioners would be asked to provide care in the public insurance and clinic-based care delivery systems or hospital systems. So to really step away from private practice, as more than half of licensed clinicians in the Commonwealth are at this point in time. The other tranche of funds, $201 million, spent in other approaches to workforce development, including $198 million pending release from the Behavioral Health Trust Fund. That work I'll talk more about in a minute is moving ahead, and other targets to emergency departments, recognizing boarding that we heard about earlier today, and the money for the pipeline development that was referenced earlier for culturally and ethnically linguistic care. If we can move ahead here, I would like to say that Tara Agarwal's conversation with us earlier today, her family's crisis is poignant, it's compelling, and it's sadly emblematic. She raised some very thoughtful questions and implied challenges, and it aligns very much with our findings in the study about actions we really need to take to solve this problem. So as we speak, the Behavioral Health Advisory Commission is making recommendations to spend $198 million in ARPA, American Rescue Plan Act funds, and federal COVID relief funds. The commission actually met yesterday and voted on a series of investments, the largest of which is going to be made in loan repayments, with additional funds in scholarships and other pipeline building initiatives. The other thing that we cannot overlook is in Massachusetts, under Chapter 257, there is a rate reserve. There is a requirement for a review of provider rates. Unavoidably, I have to say that rates are what underlies our behavioral health workforce crisis. For all the gaps in education, and Senator Markey referred to that, people not coming into the field, and people being burned out. A lot of this is driven by the fact that the rate structure has been depressed for too long in the behavioral health field. It's a discriminatory rate structure that disproportionately disadvantages behavioral health services and the people who work in those services. I want to credit the people in this Commonwealth in leadership in the administration and in the legislature and in the provider community who have taken steps in the last few years to correct the inequities. But the proportion of the inequities is so large that even the remarkable steps that have been taken are not sufficient to fix this problem. We have to do more, and we have to use the Chapter 257 rate reserve mechanism to move ahead and increase salaries available to people in this field. We can move to the next slide. In addition to some of these budget investments in direct workforce efforts, it's important to note that there are also some investments being made that need further investment that are really designed to target the needs of individuals and the needs of certain settings for expert advice and intervention. One of those is the Massachusetts Child Psychiatric Access Program, and known as MCPAP, and MCPAP for moms, and we now have also MCPAP for autism. So this is a model that really tries to employ a limited resource, that is child psychiatry or developmental pediatricians, in an economical way, strategically deploying them to a variety of settings to use their specialty to help a broader range of clinicians best meet the needs of children and youth appearing in those settings. The other is a recently formed statewide school mental health technical assistance center that is helping school districts to identify and implement best practices in prevention and early intervention in mental health education in the schools and better meeting the social and emotional and behavioral health needs of their students. These are important things for us to nourish and grow in the Commonwealth, and I wanted to call them out. I'd briefly like to talk about a couple of legislative recommendations, including the establishment of a behavioral health workforce center of excellence and efforts to streamline the licensure process to, again, make it easier for people to join the system. Finally, I just want to stress that coordination is needed across the multiple state programs here. We need to develop career ladders. This work tells us that long-term planning around workforce is critical. Blue Cross Blue Shield of Massachusetts Foundation recently identified really what they say is the need for a 10-year plan to systematically invest in addressing the workforce crisis in our Commonwealth. And I have to mention rates again. And finally, I just want to underscore, and I think it's been demonstrated by the panelists here today, the power of data combined with stories, combined with partnership, strategic partnerships among all of us, is the path to solution of this problem. Thank you very much.
Thank you, Dr. Mauch, for sharing your expertise and for your tremendous advocacy. With that, I would like to thank all of our speakers for today's session, and thank you to all that have joined us for this conversation. Also, I should note that Undersecretary for Human Services, Mary McGune, was scheduled to speak today, but unfortunately had a last-minute and urgent conflict. Secretary McGune sends her apologies for not being here today, but she also sends her appreciation to many of you for your engagement and your advocacy. To close, I would also like to offer a reminder that this session was recorded and a copy of the recording will be shared with all registrants. Lastly, if you had any questions that you submitted in the chat, or if you have any follow-up questions, please email can@childrens.harvard.edu and we will certainly get back to you. We appreciate you joining us today.